I'm going here. The committee will come to order. We are meeting this morning to consider 4 healthcare bills within the committee's jurisdiction. We will consider each bill individually with a separate opening statement and a walkthrough for each, and I will begin with my opening statement. Then I'll recognize Mr. Levin for his opening comments. So before we get started today, I just want to make a few comments. The reason we're here is to strengthen Medicare, to make the program work better. I think that's something that we all can agree upon. So I'm pleased that we are able to put together a series of bills in a bipartisan way. Let's take our first bill, the Protecting the Integrity of Medicare Act. The idea is really pretty simple. Nonpartisan watchdogs like the GAO have long said that Medicare is a high-risk program that is susceptible to fraud. And every dollar lost to fraud is a dollar lost to our seniors. So the way we see it, we have a responsibility to protect taxpayers and to protect our seniors. And we can do that by making some very common sense reforms. Take the Social Security numbers off the Medicare cards. Fix common billing mistakes. Make it easier for Medicare to procure innovative contractors to process claims. And make it easier for those contractors to communicate with our seniors. These are relatively modest changes. But you put them all together, and you have a healthier, stronger Medicare program that works better for seniors, for doctors, and for taxpayers alike. So I'm pretty proud of this bill. And I'm proud of how we put it together. This is how the process ought to work. Chairman Brady, Mr. McDermott, and many of our members worked together. They shared ideas. They held hearings. There was a discussion draft. We got feedback from stakeholders and from members. It was a collaborative process at its best. So I want to congratulate all of our members on a job well done for putting these together. Now we're also working on 3 other bills today. They will also strengthen Medicare, and they also have bipartisan support. I've said that I intend for this committee to return to regular order, and that's what we're doing here today. We're going to consider as many members' bills as we can, and that's just what we're doing here today. I want to get us back to this normal process. The members of this committee have not always seen eye to eye on health care, and that's perfectly fine, and we won't on everything. But we shouldn't shy away from our differences. But we also, when we have a chance to find common ground, to move our country forward, we shouldn't shy away from doing that as well. So the way I see it, we will have our differences, we'll have great knockdown, drag-out, respectful fights, but then let's make sure that we can also find common ground, put good legislation together, and get it moving and make a difference. And that's what we're hoping to achieve here today, and that's the way I want this committee to work. So that's the reason we're here today. And I want to thank all of our members and our staff for their hard work on this, and be happy to recognize Mr. Levin.
Thank you very much, Mr. Chairman. And I agree so much, and all of us on the Democratic side do, that this is the way the process should work. We're allowing for public comment on a discussion draft, stakeholder meetings, technical advice, and bipartisan collaboration. We hope we can continue to work in such a fashion on other policies within our jurisdiction, even when there is some substantial disagreement. These bills contain important member priorities. We do not have formal scores yet from CBO. It is indicated that they expect these bills to be revenue neutral. However, it's important to get and understand these scores, I think, before these bills move too far forward. The Program Integrity Bill, reintroduced 2 days ago by Jim McDermott and Kevin Brady, with 26 bipartisan co-sponsors, contains a number of provisions supported by both Democrats and Republicans on the committee that make important improvements to the Medicare program. These include removing Social Security numbers from Medicare cards, which protects people from identity theft, increasing protections against wrongful payments in the Medicare program, and preventing prescription drug abuse. Prescription drug abuse clearly is a serious problem. We do need to be sure that we're not making it harder for beneficiaries to get the medications they need. This is a very important principle. This language includes strong beneficiary protections to ensure that doesn't happen. The Electronic Health Record Bill, championed in the committee by Representatives Black and Sanchez, is a positive development. We have put a lot of time, effort, and resources into electronic health records going back a number of years, including the Recovery Act, and we want them to be successful. This bill is a step in helping to make the Meaningful Use program accessible to more providers. The Durable Medical Equipment Competitive Program has reduced well-documented overpayments to DME providers and is estimated to result in more than $17 billion in out-of-pocket savings for beneficiaries as well. The durable medical equipment legislation introduced in the committee by Representatives T. Berry and Larson addresses the issue of low-ball bidders by requiring bonds for companies wishing to participate in the program, importantly, without disruption to the program or beneficiary services. I also hope that this bonding requirement does not impose hardship on small or rural DME providers. There is, fortunately, a provision in the bill requiring close examination of this point. I also think the Notice Act, led in the committee by Representatives Doggett and Young, is a very positive step in the right direction. Requiring hospitals to let patients know when they are in observation status for more than 24 hours will give beneficiaries and their families the information they need when considering future care and costs. There has been a large rise in patients stuck in outpatient observation status without knowing it because their care resembles an inpatient stay. This status can have serious implications for both cost sharing and qualifying for a post-hospital stay in a skilled nursing facility. So, Mr. Chairman, again, we all join together in the use of this process. And I want to emphasize, in a sense, it's easier to use it when we all agree.
That's for sure.
But it, in a sense, is more important when there are some disagreements. And I hope that we can use this process on whatever the issue is to see if we can convene, talk things over, and if possible, work together. I think this is an important step, Mr. Chairman. We welcome it, as well as the meetings that you and I have had to talk about how we proceed. Okay, so let's proceed, and let's try to get these bills to the floor.
All right. Thank you, Mr. Levin. First order of business is a bill introduced by Mr. Brady and Mr. McDermott to protect the integrity of Medicare Act of 2015. Mr. Brady, you're now recognized for an opening statement on your bill.
Thank you, Mr. Chairman. I couldn't agree more with your opening statement. You've made it a priority to see the committee proceed through regular order on good health care legislation, and to do it in such a bipartisan fashion. That's what our constituents set us here to do. Over the last year, Ways and Means staff from both parties have worked together to get us to this point on the Protecting the Integrity of Medicare Act, or PIMA, as we call it. I want to thank all of my fellow members, both sides of the aisle, who've made this effort a priority and have worked with us to craft legislation that includes over 10 member priorities. I want to thank the stakeholders who over the last year have taken the time to weigh in, providing constructive feedback to improve the bill. And this bill will help to preserve Medicare for our seniors and reduce the rampant fraud, waste, and abuse that continues today. This is an important step, but it's not the last step. There are many other great ideas out there, and I hope that we'll all continue to work together on these efforts. Along with the other important policies in the bill, it's great to see a decade-long priority move forward for my fellow Texans, Sam Johnson and Lloyd Doggett, whose provision would protect seniors from identity theft by removing Social Security numbers from Medicare cards. The Centers for Medicare and Medicaid Services has identified also a small population within Medicare that is purposefully abusing or diverting drugs through pharmacy and doctor shopping. I've witnessed this problem firsthand with the pill mills in my communities, and I, for one, believe we need to put a stop to it. For this reason, I've included provision of PIMA that would give plans and the agency another tool, a tool that's already available in Medicaid and private insurance, to combat this behavior that is costing the Medicare program dollars and ultimately harming seniors. The negotiated language is good policy and will get to the heart of the problem while guaranteeing beneficiaries the access to medicines that they need and rightfully deserve. The policy has even made its way for the first time into the President's budget and has garnered the support of many stakeholders, which I would like to ask unanimous consent to submit those letters of support for the record, Chairman.
Without objection.
And I've said it before, I'll say it again, every dollar lost to Medicare fraud is a dollar stolen from America's seniors. And every dollar lost to improper payments, intentional or not, robs from the solvency of this important program. Sad part is this past year, improper payments actually went up from the year before. This is the time to act in educating our providers as well as the contractors that pay and audit them. We have to find ways to rein in the bad actors while getting out of the way of the providers that follow the rules and provide quality care to our seniors. Action on PEMA, I hope, will also prompt the Centers for Medicare and Medicaid Services to take on a stronger leadership role in reducing fraud, waste, and abuse. For years, we have just arbitrarily funded attempts to fix these issues. So finally, I'm happy to say we have introduced policies that reduce fraud, waste, and abuse that are paying for policies to reduce fraud, waste, and abuse. While we may not always agree when it comes to health care and its delivery, I hope that this is the start to finding solutions we can agree upon and legislate. I thank you again to my fellow members for their work, GAO and OIG for their sustained effort, and the stakeholders for their input. And with that, Mr. Chairman, with that, I yield back.
Thank you. I'd now like to yield time to Mr. McDermott for any opening statement he might have on the bill.
Thank you, Mr. Chairman. I want to begin by thanking Chairman Brady for collaborating and putting this all together. We had it together in the last Congress. We couldn't get it to the floor, so now we get it back here and we're ready to go. In particular, I'm pleased with his willingness to include 3 bills that I put in the last session having to do with fraud and abuse. My whole belief is that as we change the healthcare system in this country, as we are with the ACA, we have to rethink some of the fraud, waste, and abuse situations were directed straight at fee-for-service. We're changing from fee-for-service to a payment for value, and that gives us some new interesting organizations to look at and will give us some places we have to look for prevention of fraud. The first bill is a small but significant change to the statute. Currently, the requirement in the law requires that a physician document that a face-to-face occurrence or encounter has occurred before ordering durable medical equipment. Now, the face-to-face encounter requirement is important in preventing fraud and abuse. You want somebody to actually have seen it. However, non-physician providers are allowed to conduct face-to-face encounters. A quirk in the law only allows physicians to certify that these encounters have occurred. So we're correcting that. It's common sense. The second provision corrects a drafting error, which limits CMS' ability to require home health agencies to post surety bonds as a condition of participation in the Medicare program. The ACA allows CMS to base the amount of a surety bond on the volume of payments a home health agency receives from Medicare. However, the text of the statute inadvertently limits CMS' ability to implement this requirement by capping the amount of bonds. Requiring home health agencies to post a surety bond allows regulators to fight fraud and recoup overpayments. Strengthening that requirement brings the text of the law in line with congressional intent and really improves the integrity of the Medicare program. The third provision in this bill makes a small change in the civil monetary penalty law in order to promote gain-sharing arrangements. That's this new stuff that's coming with ACOs. These gain-sharing arrangements are new in the law, therefore we have to change the fraud law. This will allow health providers to coordinate in ways that reduce medically unnecessary services. As the ACA moves forward toward a payment system that prioritizes value over volume, we need to continue looking for ways to facilitate this transition. Modernizing the fraud and abuse laws without undermining their effectiveness is an important part of that effort. We all care about fraud. And I hope these 3 provisions can serve as a reminder that rather than trying to tear apart the Affordable Care Act, we can work together to find ways to make it work. No legislation is ever perfect. I've been involved in this for a long time, and I never wrote a perfect bill. And I don't think anybody up here has ever participated in a perfect bill. So you have to keep looking and keep amending and changing as you realize things you didn't know. Finally, I would be remiss if I didn't talk about the limitations of this bill. In particular, Kevin and I talked a long time about this, about what to do about it, and I'm disappointed we have not addressed the issue of fraud in Medicaid, not Medicare, but Medicaid. Medicaid, like Medicare, is vulnerable to fraudsters, unscrupulous providers, and other bad actors. Unfortunately, federal fraud and abuse laws do not always apply to Medicaid with full force. Specifically, the physician self-referral law exists in a state of ambiguity that has undermined its enforcement in the Medicaid context. Because of this, many providers who engage in inappropriate ownership and compensation arrangements have evaded penalties simply because Medicaid is the payer, not Medicare. We need to close this loophole and provide certainty that stakeholders certainty to stakeholders about their obligations under the law. Now, I've been around here long enough to know about jurisdiction of committees. And I've drafted a letter to the Committee on Energy and Commerce asking them to hold a hearing on this subject because it's in their jurisdiction, and I'm sure they don't want to have fraud, waste, and abuse occurring because they've refused to look at making the application of the law. Moving forward, there are a lot of other things to do, and I think that this should be the start of a process. There are many things about the ACA that need to come before this committee, and we ought to discuss them. And I hope the chairman will, well, I know the chairman of the subcommittee would like to do some of it. I want the full chairman to weigh in as well on this whole business. I ask unanimous consent to enter into the record the letter that I sent to the Commerce.
Without objection.
Thank you.
Thank you. The committee will now proceed to consideration of H.R. 1021. Without objection, the measure will be considered as read and open for amendment at any point. I offer an amendment in the nature of a substitute, which was distributed in advance, along with a green sheet explaining it. Without objection, the amendment in the nature of a substitute shall be considered as read, open for amendment at any point, and considered as base text for the purpose of amendment. I will now turn to Matt Hoffman, Staff Director of the Health Subcommittee, to provide the technical description of the amendment in the nature of a substitute. And I ask that members hold off their questions until after his presentation. Mr. Hoffman.
The amendment in the nature of a substitute makes two changes to the underlying bill. First, with respect to Section 12, it narrows the scope of the provision to focus only on Schedule II drugs. And second, with respect to Section 19, it changes the date when the Secretary must report a plan to expand the comprehensive error testing rate report to June 15, 2015.
Any questions for Mr. Hoffman? Yeah, Mr. Thompson.
Question on PEMA. Is it now the appropriate time to ask?
Yes.
Okay. I'm very supportive of this bill. I think it does all the things that we want to do. I just have one question. I hope your answer will mean that I don't have a concern. In Section 12 of the bill, it creates the drug management program for at-risk beneficiaries. And the language outlines several of the stakeholders, the beneficiaries, the advocacy groups, the clinicians, and the plan sponsors, and says that they should be part of the rulemaking process, correct?
Yes.
However, it doesn't say anything about pharmacies and pharmacists. Will they have a seat at the table? Because they're not specifically mentioned in the bill's language.
Yes, that's the intent of the bill. They will have a seat.
They will have a seat? Okay, thank you very much.
Any other further questions for Mr. Hoffman on PEMA? All right. Let me get to the tab here. What's that? We got the votes. Any further discussion? I know there are a lot of members who have provisions in this bill. Are there any members who want to talk about their provisions? Mr. Doggett.
Thank you very much, Mr. Chairman. I think it is good we can seek common ground. Actually, Mr. Johnson and I found common ground about 8 years ago on the Medicare issue that Mr. Brady has included in this bill, which I'm appreciative for. With identity thefts becoming more sophisticated, a little prevention can go a long way. This important aspect of the bill seeks to protect the privacy of about 50 million Medicare beneficiaries by removing Social Security numbers from the Medicare cards. This is something that I first began working on in 2008. We found common ground, but we couldn't find common ground with some of the bureaucracies that were involved. I introduced legislation in the 110th Congress, which Mr. Johnson co-sponsored. We passed it through the House of Representatives, but could not get the Senate to act on it. Mr. Johnson, as the Republicans took charge of Congress, took over the lead role on this legislation, and I joined him as a co-sponsor. I appreciate his leadership and the efforts that have been made over the course of the last almost 8 years to get this legislation approved, and I hope that finally we will be able to get Senate approval and actually see it signed into law and become effective to protect those who are very much the target of identity theft. They may still face other perils, but we need to ensure that we're not making it easy for identity thieves to get their Social Security number. And I yield back, and thank you, Mr. Chairman.
Thank you, gentleman. Yields back his time. Mr. Johnson is recognized.
Thank you, Mr. Chairman. Thanks for bringing up 1021 today, which includes a provision of ours, along with Mr. Doggett, to prohibit the inclusion of Social Security numbers on Medicare cards. It's an effort Mr. Doggett and I have worked on for several years, and I hope on behalf of the millions of seniors out there that we finally get this done. Bottom line is, if we really want to get serious about identity theft, then we need to once and for all take the Social Security number off the Medicare card. You see, the Social Security number is the key to identity theft, and thieves know that. In fact, back in 2013, then Texas Attorney General Greg Abbott issued an ID theft alert to seniors because crooks were trying to scam seniors into giving their Medicare numbers under the ruse that the Medicare was issuing new cards and that the numbers were needed in order to continue to get the benefits. And he got that in the paper, and we're fixing it today, and I thank you for that, Mr. Chairman.
Absolutely. Thank you. Mr. Roscom, do you
Thank you, Mr. Chairman. There's a number of provisions that are included in PEMA that the genesis of which is the PRIME Act that I've been pleased to introduce in the past, and I'm joined by Mr. Blumenauer and Mr. Kind, Ms. Black, Mr. Paulson, and Mr. Renacci. I especially want to thank my Democratic co-lead on that bill, Mr. Carney of Delaware, and particularly Chairman Brady, who has guided this process and has been an incredible advocate all the way around. Just want to point out one provision in particular that now would require the Secretary to develop initiatives for states to participate in what's known as the Medi-Medi program. In other words, there's right now 21 states that participate in the Medicare-Medicaid data match program. Said another way, there's 29 states that don't. And it doesn't make any sense for them not to participate. In other words, it sets up a comparison for claims data from federally run Medicare and state-run Medicaid to protect against potential fraud and abuse patterns. So what the Secretary would be tasked to do is to create incentives for states to participate in this to make sure that if a physician has been banned by a state from participating in Medicaid, then that physician can't participate in Medicare. Or if there's someone who has passed away and Medicare has that information, to make sure that that data is passed on to the states. Very common sense, and it's one of these ideas, Mr. Chairman, that you've been prompting the committee to move forward on, and I appreciate your leadership all the way around. I yield back.
Thank you. Mr. Renacci, do you wish to be recognized?
Thank you, Mr. Chairman, and I'm pleased the Better Efficiency and Administrative Simplification Act is including in the Protecting the Integrity of Medicare Act. And I'd like to start by thanking my colleague Bill Pascrell for joining me in introducing this legislation. I also want to thank Chairman Brady and Mr. McDermott for their leadership in crafting this bipartisan legislation. We live in an era where there is an option to virtually receive every bill notice, whether it's credit card bill or utility bill, in your email box. Not only does an email option dramatically reduce costs for an organization, paperless is definitely a growing preference. When does the federal government not take advantage of sending paperless bills for Medicare summary notices? It's interesting, a constituent from North Canton actually asked me this question and expressed concern about wasteful government spending, and that is why I introduced this common sense legislation. This act allows beneficiaries to receive their Medicare summary notices by email, but does not require it, which will potentially save millions of hardworking taxpayer dollars. It also gives CMS the authority to allow beneficiaries to receive their Medicare summary notices more frequently, and to expand the email option to other beneficiary documentations. Increasing this frequency of these notices is significant because the beneficiary is typically the first line of defense against fraudulent billing practices. The sooner beneficiary can report incorrect billing, the sooner government can stop the payments from going out. This legislation also includes provisions to make the contracting process for Medicare administrative contractors more efficient and effective. Current law requires CMS to recompete MAC contracts at least every 5 years. Because the terms of these contracts are staggered, CMS finds itself in a continuous cycle of procurement. The continuous cycle forces CMS to recompete the contracts of high-performing MACs every 5 years, diminishing the resources of the agency has available to replace poor performers. HHS Office of Inspector General identified this continual cycle of procurement as a source of waste within CMS and recommended the changes. This legislation extends the mandatory recompete timeline from 5 years to 10. Importantly, CMS retains the ability to recompete any MAC contract sooner than the 10-year mandatory limit. By giving CMS additional flexibility to prioritize their procurement, this legislation takes a common sense approach to reducing unnecessary waste. Again, I want to thank Chairman Brady and Mr. McDermott for putting this bill together, and I yield back.
Thank you. Mr. Pasquarello, do you wish to be recognized?
Thank you, Mr. Chairman. I want to thank Mr. Brady and Mr. McDermott for the hard work that they've put into this and their staff. I'm pleased that the bill I introduced with Congressman Bastani, the facilitating participation in clinical data registries, was included in the Protecting the Integrity of the Medicare Act. Mr. Chairman, there is broad interest among hospitals and providers in participating in clinical data registries, which have been shown to help improve clinical outcomes and appropriate utilization, and providing comparative effectiveness data and reducing costs. A current lack of guidance leaves hospitals and providers unsure about what steps need to be taken in order to comply with patient privacy requirements before submitting their data to a clinical data registry. Hospitals, providers, registries are spending millions of dollars dedicating a significant amount of resources to sorting through this lack of clarity about what the law requires, which is creating unnecessary barriers to registry participation. The provision included in PIMA provides much-needed guidance for hospitals and healthcare providers to implement clinical data registry efficiently. More and more of us, Mr. Chairman, are getting requests from folks, particularly in the development of and responding to rare diseases. I think this is a critical part. And, Mr. Chairman, I would just like to thank you for having this markup today. I hope they become a regular occurrence. I would urge the committee to consider legislation that I introduced with Congressman Kinzinger, which has over 100 bipartisan co-sponsors, and I think it's important. And I thank you for the time, and I yield back.
Thank you. Mr. Reichert, do you wish to be recognized?
Thank you, Mr. Chairman. And as been stated, this legislation contains several bipartisan policies, including legislation that Mr. Lewis and I recently introduced, originally known as H.R. 943, the Medicare Employer Relief Act. And so I want to thank Chairman Brady and Ranking Member McDermott for working with Mr. Lewis and I, and including this language in Section 18 of this bill. Briefly, the language removes redundant and burdensome reporting policies for employees. Specifically, it repeals a redundant requirement for employer disclosure of information regarding the health care coverage of employees who are Medicare beneficiaries. This is another one of those common sense fixes that saves the federal government and American businesses lots of time and lots of money. So by repealing this outdated version of the law, we are going to become a lot more efficient and save money. So appreciate Mr. Lewis's cooperation on this, and again, thank the chairman and the ranking member, and I yield back.
Thank you. Mr. Blumenauer, do you wish to be recognized?
Thank you, Mr. Chairman. It is, I think, critical that we're able to take these areas where we do agree and be able to move them forward. I appreciate, Mr. Brady, we had, I think, a half dozen areas in the last Congress that we discussed, and where there was consensus that had emerged. I appreciate Mr. Roskam's leadership on this. I think this is a terrific element that is, just because politicians talk about fraud, waste, and abuse doesn't mean that it doesn't exist. And this is, I think, an important step to move it forward. I also appreciate having the element in here dealing with requiring the Secretary to examine using smart card technology. There's opportunities here, and has been referenced in other elements, that technology is going to help us a great deal. And I must, Mr. Chairman, note our friend Jim Gerlach, with whom I worked on this provision for a number of years, who's no longer a member of the committee, but who is passionate about unlocking the potential here. And I'm pleased that the legislation that I've worked on with him is there, and I know he will be happy. Thank you, Mr. Chairman.
All right. Does anybody else seek recognition? All right. If no further members seek recognition and there are no further amendments, the question is on the adoption of the amendment in the nature of a substitute. All those in favor signify by saying aye. Aye. Those opposed, no. In the opinion of the chair, the ayes have it, and the amendment in the nature of a substitute is agreed to. I will now recognize Mr. Johnson for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 1021 as amended to the House of Representatives.
The question is on favorably reporting H.R. 1021. All those in favor signify by saying aye. Aye. Those opposed signify by saying no. In the opinion of the chair, the ayes have it, and the motion is agreed to. H.R. 1021 is ordered favorably reported. Without objection, I ask that the staff be authorized to make technical and conforming changes to the bill, and that members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. The second order of business today is a bill introduced by Mr. T-Berry and Mr. Larson, the Medicare Deposed Competitive Bidding Act. Sorry, it's a typo. It said Mrs. Larson. Sorry. No, it wasn't my tongue.
Talking about the brains in the...
We'll get that fixed next time. The Medicare Deposed Competitive Bidding Improvement Act of 2015. Mr. T-Berry, you are now recognized for an opening statement on your bill.
Thank you, Mr. Chairman. Thank you for holding this markup today, and I'm pleased to introduce H.R. 284, the Medicare Competitive Bidding Improvement Act, with my colleague, Mr. Larson of Connecticut. This bill fixes a fundamental flaw in the Medicare DME competitive bidding program by requiring binding bids. It will promote fair competition, better protect our seniors, and support small business owners. The DME includes items like home oxygen, blood sugar monitors, and walkers. And the competitive bidding program was intended to reduce out-of-pocket costs for seniors. However, over the last several years, we have seen that it has become clear that the current bidding process is flawed, in large part because bids are not binding. This encourages low-ball bidding, which artificially drives down prices and will eventually lead to market failure. I've heard from beneficiaries, small business suppliers throughout my state of Ohio that this program is impeding access to needed items for our seniors and harming health care outcomes. This is absolutely unacceptable. The goal of the bill is to reduce the number of bad actors participating in the program by imposing a penalty if the supplier does not accept the contract to which they were awarded. This bill will help ensure that suppliers submit bids that are in good faith, create more certainty for suppliers and, more importantly, our seniors, and increases access to more quality products and services. I encourage my colleagues to support this bill, and I thank Mr. Larson for his partnership on this, and I thank the chairman and his staff and the chairman of the Health Subcommittee and his staff for holding this markup, and I yield back.
Mr. Larson, you're recognized for an opening statement on your bill.
Well, thank you, Mr. Chairman, and I would like to commend Chairman Teaberry for his efforts. It's always a pleasure to work with him on several different endeavors on this committee and outside of this committee. And he does his usual thorough job. I think he has stated the parameters of the bill very well. The issue was lowball bidding. As he has heard in Ohio, and I'm sure many of you had heard in your states as well as I have heard in mine, the issue with so many individuals who felt that they would be directly impacted by this. I commend the committee and the staff, and further want to point out that the provision to have GAO look at how these new provisions would impact small community providers, and if any further problems shall arise, recommend changes to ensure that a robust participation of small suppliers exists, providing as well that those small providers in their communities have the kind of access and the dependability and familiarity that so many of our constituents have come to expect. Again, Chairman Ryan, I want to commend you and Ranking Member Levin for your great help and this initiative, and yield back the balance of my time.
Thank you. The gentleman yields back the balance of his time. The committee will now proceed to consideration of H.R. 284. Without objection, the measure will be considered as read and open for amendment at any point. I offer an amendment in the nature of a substitute, which was distributed in advance along with a green sheet explaining it. Without objection, the amendment in the nature of a substitute shall be considered as read, open for amendment at any point, and considered base text for the purpose of amendment. I will now turn to Matt Hoffman, Staff Director of the Health Subcommittee, to provide the technical description of the amendment in the nature of a substitute, and I ask members to hold off on their questions until after his presentation. Mr. Hoffman.
The amendment in the nature of a substitute makes several changes to the underlying bill. It clarifies the intent of the legislation, it makes terminology more consistent with what is used in statute and regulation, and requires GAO to issue a report on the legislation's impact on small suppliers.
Are there any questions for Mr. Hoffman? There being no further questions, are there any amendments to the amendment in the nature of a substitute?
Mr. Chairman?
Mr. Teaberry.
Mr. Chairman, I have an amendment.
I understand copies of the Teaberry amendment have been shared with the minority and distributed in advance. Without objection, the amendment is considered as read. And we thank Mr. Levin and his staff for working with us on this amendment. And the gentleman from Ohio is recognized.
Thank you, Mr. Chairman. I'd like to offer an amendment to the amendment in the nature of a substitute that is technical, as a technical change to the bill requested by CMS for more congressional discretion. And I'd like to thank Mr. Larson and his staff for working with us through this issue.
Thank you. Is there any further discussion, Mr. Larson?
Ditto.
Okay. Anybody else want in on this? Mr. McDermott?
We checked with CMS, and they suggested that these words would be difficult for them to deal with, and that's why this is a technical amendment.
Right. That's correct. It is because once the amendment in the nature of a substitute had been published, then CMS came and asked for more clarification and direction, thus the need for this amendment.
That's correct, Mr. Chairman.
Yep. Any further discussion? As no other member seeks recognition, the question is on agreeing to the amendment offered by Mr. Teaberry. All those in favor signify by saying aye. Aye. Those opposed, no. And in the opinion of the chair, the ayes have it. Are there any additional amendments to the amendment in the nature of a substitute? Seeing that there are no additional amendments, the question is on the adoption of the amendment in the nature of a substitute. All those in favor signify by saying aye. Aye. Those opposed, no. In the opinion of the chair, the ayes have it, and the amendment in the nature of a substitute is agreed to. I'll now recognize Mr. Johnson for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 622 as amended.
284.
Excuse me, 624 as amended.
284.
Okay. How about let's try 284 as amended to the House of Representatives.
Just getting the record right, that's all. Yeah, that's right. Yeah, we almost snuck one by you there. The question is on favorably reporting H.R. 284 All those in favor signify by saying aye. Aye. Those opposed, no. In the opinion of the chair, the ayes have it, and the motion is agreed to. H.R. 284 is ordered favorably reported. Without objection, I ask that staff be authorized to make technical and conforming changes to the bill, and that members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. Our third order of business is a bill introduced by Mr. Doggett and Mr. Young, the Notice of Observation, Treatment, and Implication for the Care Elderly Act. That one's a mouthful. Mr. Doggett, you are now recognized for an opening statement on your bill.
Thank you very much, Mr. Chairman. The Notice Act, as the name suggests, is about giving notice. And in this case, it is notice to patients when they're about to be billed personally in a hospital, perhaps for thousands of dollars, after being placed in the category of under observation, usually without them knowing about it. I'm pleased to have worked together on this legislation with Mr. Young. Currently, a hospital may either admit a patient as an inpatient or keep the patient under observation. When it comes to what difference that makes in terms of health care, it appears to usually be indistinguishable, particularly to the patient involved. But the economic implications can be extreme if the patient later requires care in a skilled nursing facility. Medicare would pay for such needed care for a Medicare recipient who's in the hospital for more than 3 days as an inpatient, but would not pay for it if the patient were receiving the same care in a category called under observation. Nationwide, many of those who rely upon Medicare are being put under observation for a length of time that exceeds the guidelines that have been set by Medicare. And this problem seems to be accelerating. According to one recent report, over a 6-year span, the number of stays that were categorized as under observation rose by 88%. On the NBC Nightly News, Kate Snow profiled Ms. Kelly Neelam, who discovered that her hospital had categorized or classified her husband, who was there, as under observation. Finally, after repeated questioning and demanding to know why this category has been applied, she finally got the hospital to reclassify him as an inpatient. Without her advocacy, she learned that the family would have faced out-of-pocket, from their pocket, $22,000 in rehabilitation bills. Last year, in the wake of increasing reports about how many patients are faced with this problem and insurmountable out-of-pocket cost for skilled nursing care for seniors, the column in the New York Times, the new old age, I think it's caring and coping column to provide advice to seniors. Susan Jaffe wrote a guide to what seniors can do to avoid this classification. But I think clearly the most effective advocate for them and the most effective way for them to advocate is for the patients to know, to have notice of what is occurring here. This bill has been endorsed by the AARP, the Alliance for Retired Americans, the Center for Medicare Advocacy, the National Association of Professional Geriatric Care Managers, Leading Age, the American Healthcare Association, and the National Committee to Preserve Social Security and Medicare. It is bipartisan. There are times when the hospital, having acted in the best interest of the patient's health, may not have also acted in the best interest of the health of the patient's pocketbook. The Notice Act equips patients and their loved ones with the knowledge that they need to be effective advocates and to avoid crippling financial repercussions. And I thank Mr. Brady for his staff's work on this measure as well, and certainly Mr. Young, and yield back.
Thank you. Mr. Young, recognized for your bill.
Thank you, Mr. Chairman, for taking up this important piece of legislation today. I want to thank my colleague, Mr. Doggett, for his strong leadership on this issue. When seniors require a hospital stay, they're rightfully more concerned with the recovery that they aim to achieve than with understanding how the hospital classifies their status as a patient. But when that classification can impact future coverage of healthcare services related to their recovery, they deserve to be made aware of the potential ramifications. The Notice Act would require hospitals to provide meaningful written and oral notification to patients who are in the hospital under observation for more than 24 hours. This notice would alert the beneficiary or person acting on their behalf of the Medicare patient's admission status and the financial implications of that classification, so he or she can advocate on their own behalf while in the hospital. No one should be caught off guard by a large medical bill just because they weren't aware of status codes and billing procedures. In a time of sickness and stress, families should focus on the recovery of their loved ones instead of dealing with the hidden costs due to lack of notice. Thank you, and I yield back.
Thank you. The committee will now proceed to consideration of H.R. 876. Without objection, the measure will be considered as read and open for amendment at any point. I offer an amendment in the nature of a substitute, which was distributed in advance along with a green sheet explaining it. Without objection, the amendment in the nature of a substitute shall be considered as read, open for amendment at any point, and considered base text for purpose of an amendment. I will now turn to Matt Hoffman, the Staff Director of the Health Subcommittee, to provide the technical description of the amendment in the nature of a substitute. I ask members to hold their questions until after his presentation. Mr. Hoffman.
The amendment in the nature of a substitute makes several technical changes to the underlying bill. It establishes an effective date, clarifies the timing of the sunset provision, and requires the Secretary to determine that certified electronic health record technology is applicable to the ambulatory surgical center practice setting in consultation with the public.
Any questions for Mr. Hoffman?
I would just say thank you, Mr. Chairman, for Mr. Hoffman and the assistance of your staff and Mr. Brady's staff in making these changes, which I support.
Absolutely, our pleasure. Anybody else seek to ask questions, or anybody have a comment? If there are no further comments and if there are no further amendments, the question is on the adoption of the amendment in the nature of a substitute. All those in favor signify by saying aye. Aye. All those opposed, no. In the opinion of the chair, the ayes have it, and the amendment in the nature of a substitute is agreed to. I will now recognize Mr. Johnson for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 876 as amended to the House of Representatives.
The question is on favorably reporting H.R. 876. All those in favor signify by saying aye. Aye. Those opposed signify by saying no. In the opinion of the chair, the ayes have it. The motion is agreed to. H.R. 876 is ordered favorably reported. Without objection, I ask that the staff be authorized to make technical and conforming changes to the bill, and that members may have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. Third order of business. It is a bill introduced by Ms. Black and Ms. Sanchez, the Electronic Health Fairness Act of 2015. Ms. Black, you are now recognized for an opening statement on your bill.
Thank you, Mr. Chairman. I thank you for the consideration of this very important bill, the Electronic Health Fairness Act. I also want to thank Representative Sanchez for co-sponsoring this important piece of legislation and Mr. Buchanan for his support as well. We all know that electronic health records have the potential to improve the quality, safety, and efficiency of care that our providers are able to offer patients. The use of such technology should be encouraged, but reforms are desperately needed to reach the promise of EHRs. In particular, we must ensure that the regulatory structure of the program encourages better, more efficient care, not the opposite. Beginning this year, the EHR Meaningful Use Program requires physicians to conduct at least 50% of all of their Medicare patient encounters in a setting with a certified EHR technology or face harsh penalties. There are currently no certified EHRs in ambulatory surgical center settings due to the unique nature of ASCs, so providers that serve the majority of their Medicare patients in these settings could be penalized because they will not be able to meet the encounter threshold. The Electronic Health Fairness Act is simple, but an important bill. It merely exempts any patient encounters that take place in an ASC from counting toward the EHR meaningful use threshold. This bipartisan legislation would protect the providers who conduct the majority of their care in these settings from illogical penalties, while removing a major disincentive to conduct care in an AHC where appropriate. ASCs serve as a low-cost, high-quality setting for providers and their patients throughout the country. Physicians conduct numerous and diverse sets of procedures in ASCs. The impact of penalties would likely have a disproportionate effect on ophthalmologists, gastroenterologists, and orthopedists, who frequently utilize ASCs to perform the majority of their medical procedures. All of these services are vital to caring for our nation's seniors. It is imperative that we protect providers that are otherwise following the law from costly, unfair penalties. I firmly believe that physicians should be encouraged to perform procedures in the most appropriate setting for their patients and not face substantial penalties because of an appropriate site of service that does not meet a particular regulatory requirement that has nothing to do with quality of care. Thank you, Mr. Chairman, and I yield back the remainder of my time.
Thank you. Ms. Sanchez, would you like to be recognized for your bill?
I would. Thank you, Mr. Chairman, for the opportunity to speak about the Electronic Health Fairness Act. I almost didn't make it here in time today to speak on the bill, so I appreciate that you held it towards last. But it's a mystery to me as to why, when federal government offices are on a 2-hour delay, Congress, for some reason, isn't. I had to get my son safely to school, and it's a tough choice sometimes that working moms have to make between.
I apologize to the general lady from California. Those of us from Wisconsin, it's just like any other day for us. So,
when you come from California, this is most certainly not like any other day.
So.
So perhaps it's a difference in perspective from where one originates. I just wanted to point that out, though, because it is often, those tough choices that working moms have to make. So, again, I do appreciate the chairman's indulgence in holding the bill till last, and I appreciate Ms. Black's staff and her work on this bill today. This bill is an important bill because it would help the ambulatory surgery centers around the country, especially 8 ASCs in my district. ASCs, as they're known, consistently receive high patient satisfaction rates and provide a wide range of surgical procedures from colonoscopies to ophthalmic procedures. By avoiding a hospital visit for simple outpatient procedures, ASCs provide physicians with a low-cost option to perform these surgeries while also giving the patient the peace of mind to be back in their homes by the end of the day. Unfortunately, current law forces a physician to choose between providing quality, cost-effective care in an ASC or sending Medicare patients to a higher cost setting in order to avoid financial penalty. The HITECH Act of 2009 sought to codify the widespread adoption of electronic health record, EHR technology, to deliver quality care and improve care coordination. Unfortunately, ASCs were not included in the HITECH Act, so physicians in the ASC setting are not eligible for incentive payments and at risk of violating the quote-unquote meaningful use thresholds. Further, with no certified EHRs for the ASC setting, any patient encounters that occur in an ASC would not count towards meaningful use thresholds. The Electronic Health Fairness Act would simply level the playing field for physicians seeing patients in an ASC from counting toward the EHR meaningful use threshold until the Secretary of Health and Human Services determines that certified EHR technology is applicable to the ASC setting. I'm pleased that the Ways and Means Committee is gathered here today to combat fraud and improve certain elements of Medicare. We should go one step further and pass this bill to ensure that we are protecting law-abiding providers from unfair penalties. Again, I thank the chairman, and I yield back.
Thank you. The committee will now proceed to consideration of H.R. 887. Without objection, the measure will be considered as read and open for amendment at any time. I offer an amendment in the nature of a substitute, which was distributed in advance, along with a green sheet explaining it. Without objection, the amendment in the nature of a substitute shall be considered as read, open for amendment at any point, and consider base text for the purpose of an amendment. I will now turn to Matt Hoffman, Staff Director of the Health Subcommittee, to provide technical description of the amendment in the nature of a substitute, and I ask members to hold off on their questions until after his presentation. Mr. Hoffman, you're recognized.
The amendment in the nature of a substitute makes several technical changes to the underlying bill. It establishes an effective date, clarifies the timing of the sunset provision, and requires the Secretary to determine that certified EHR technology is applicable to the ASC practice setting in consultation with the public.
Any questions for Mr. Hoffman? Any further comments about the bill? If there are no further comments, questions, or amendments, the question is on the adoption of the amendment in the nature of a substitute. All those in favor signify by saying aye. Aye. All those opposed, no. In the opinion of the chair, the ayes have it, and the amendment in the nature of a substitute is agreed to. I will now recognize Mr. Johnson for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 887 as amended to the House of Representatives.
The question is on favorably reporting H.R. 887. All those in favor signify by saying aye.
Aye.
All those opposed signify by saying no. In the opinion of the chair, the ayes have it, and the motion is agreed to. H.R. 887 is ordered favorably reported. Without objection, I ask that the staff be authorized to make technical and conforming changes to the bill, and that members may have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. There being no further business before the committee stands adjourned.
Hey, good job.
1 hour. That's super. Bless you.